Assalamualaikum and good day to my lecturer, Ms. Najiha, and to all my fellow group mates. So today, me, Muhammad Mubarak Ali bin Rahmatullah, and my fellow group mates, who are Nishandra Pubalen, Marwa Kushaira, and Noor Adila Nabiha, will be presenting on the topic Disseminated Intravascular Coagulation Disease. So let's dive right into the content. So, what is disseminated intravascular coagulation? Also known as DIC, is a rare life-threatening condition in the early stages of the condition. DIC causes your blood to clot excessively. As a result, blood clot may reduce blood flow and block blood from reaching bodily organs. As the condition progresses, platelets and clotting factors, the substance in your blood responsible for forming the clots, are used up. When this happens, you will begin to experience excessive bleeding. So let's see the etiology. The first one is obstructive complications. Okay, the first one is the amniotic fluid embolism, which is characterized by acute and rapid collapse of mother and or baby as a result of an allergic-like reaction to amniotic fluid entering the maternal circulatory system. Second is eclampsia. So eclampsia is a condition where high blood pressure results in seizures during pregnancy. Third one is the premature separation of placenta. And the fourth one is the retained dead fetus. So the second cause of DIC is malignancies. First is acute myelocytic leukemia, also known as APL. This is an aggressive type of acute myeloid leukemia in which there are too many immature blood-forming cells called promyelocytes in the blood and bone marrow. This buildup of promyelocytes leads to a shortage of normal white and red blood cells and platelets in the body. Second is adenocarcinoma. This is a type of cancer that starts in mucus-producing glandular cells in the body. Many organs have these glands, and adenocarcinoma can occur in any of these organs. Common types includes breast cancer, colorectal cancer, lung cancer, pancreatic cancer, and prostate cancer. Okay, the third category is called infections. Okay, so the first one is septicemia. So septicemia is a serious bloodstream infection. It's also known as blood poisoning. Okay, septicemia occurs when a bacterial infection occurs elsewhere in the body, such as at the lungs or the screens, and then it enters into the bloodstream. Okay, so this is dangerous because the bacteria and their toxins can be carried through the bloodstream to the entire body. Okay, second is septic abortion. So this is an infection of the placenta and fetus of a pre-viable pregnancy. Okay, infection is centered in the placenta and there is a risk of spreading to the uterus, causing pelvic infection or becoming systemic to cause sepsis and potential damage of distant vital organs. The last one is the gram-negative sepsis. So as we all know, gram-negative bacteria causes infections, including pneumonia, bloodstream infections, wound or surgical site infections. Okay, and another cause of this DIC is that secondary fibrinolysis. Okay, so fibrinolysis gets activated and FDP's D-dimer formed has an inhibitory effect on clot formation. So plasmin formed inactivates F5, 7, 9, and 10. These are the clotting factors which further inhibit intrinsic coagulation cascade. So the final group for causes is miscellaneous. So the first one is snake bites, severe burns, anaphylaxis, and giant hemangioma. Okay. So what are the risk factors involved in DIC? So as we have seen the etiology just now, so all of those are the risk factors involved. So let's see: blood transfusion reaction, cancer, especially certain types of leukemia, inflammation of the pancreas, infection in the blood, especially by bacteria or fungus, liver disease, pregnancy complication, usually when the placenta is still left behind after delivery, recent surgeries or anesthesia, severe tissue injury such as burns or head injury, and large hemangioma. This is a blood vessel that is not formed fully. So that is all for my part. My group mate Nabiha will continue further on this. Thank you.
Okay, Assalamualaikum. My name is Nabiha and I am going to present about prevalence and epidemiology. Okay, disseminated intravascular coagulation, which is DIC, may occur in 30 to 50% of patients with sepsis, and it develops in an estimated 1% of all hospitalized patients. DIC occurs at all ages, all races, and no particular sex predisposition has been noted. Histologic studies in patients with DIC show the presence of ischemia and necrosis due to fibrin deposition in small and medium size vessel of various organs. Specific thrombotic complications that are sometimes seen in the framework of DIC are acral cyanosis, hemorrhagic skin infarction, and limb ischemia. On 2016, a total of 8,000 um, in 2016, a total of 704 admissions were identified with a diagnosis of DIC. The percentage of admission in females and males are females are 50.57% and the males are 49.43%, which is shown has no noticeable difference between female and male. The disease specific mortality for DIC was 47.7%. Okay, African Americans with DIC admissions were found to have 24% more risk of dying compared to Caucasians, while the Native Americans has 67 more risk of dying compared to Caucasians. The mortality rate with DIC for Native American was 57%, while African American 52% and Caucasians 47%. Okay, the next one is symptom and clinical manifestation. The symptoms of disseminated intravascular coagulation are often those of underlying inciting condition. Such conditions may include sepsis, trauma, organ dysfunction, and malignancy. Malignancy, which are the solid tumors, and lymphoproliferative malignance. Patients with pulmonary involvement may present with dyspnea, hemoptysis, and cough. In patients with subacute DIC, the primary manifestation is thrombosis from the excess thrombin formation. Besides that, the signs may present bleeding into the serous cavity, non-specific altered consciousness, hypotension, tachycardia, signs of acute respiratory distress syndrome, hematuria, and jaundice. So that's all from me. I will pass next to Nisha. Thank you.
Greetings to my lecturer. My name is Nishandra and I'm going to be presenting on the pathogenesis of disseminated intravascular coagulation. There are four phases in the pathogenesis, which is activation of coagulation, thrombotic phase, consumption phase, and the secondary fibrinolysis phase. Now, there are distinctive triggering mechanisms that has been identified for different injuries, but this is a general sequence of event that happens in the vessel during coagulation. So to begin off with the activation of coagulation, now what what activates coagulation is all of the etiological factors that has been mentioned earlier. Now, when there is an cause, which is usually injuries, when there's an injury, what happens is that the injury causes the release of tissue factors into the circulation, which then activates the coagulation. Now, what happens next is that in the thrombotic phase, when there is an endothelial damage, what happens is that the platelet aggregation happens. Platelet aggregation and adhesion happens, which causes the deposition of small thrombi and embolies in the circulation of the vessel. Now, what happens to the thrombi and emboli is that they become the microthrombi in the circulation throughout the vessels. Next is the consumption phase. What happens in the consumption phase is that the platelets and the tissue factors or the coagulation factors are being used up here. Coagulation factors and platelets are being used up in the consumption phase. The last phase is the secondary fibrinolysis phase. Just with its name, we know that it is a breakdown of fibrin. Secondary fibrinolysis is actually a protective mechanism fibrinolytic system, which is secondarily activated at the site of intravascular coagulation. What happens during this phase is that fibrins are being broken down and they are present as fibrin degradation products in the vessels. What happens by end of the secondary fibrinolysis is that the coagulation factors decrease, the platelets decrease, and there's also presence of fibrin degradation products in the circulation. Moving on to the pathophysiology of the disseminated intravascular coagulation, as I've mentioned earlier, there are distinctive triggering mechanisms. Now, to look at it is tissue injury and sepsis will cause tissue thromboplastin to be released into the circulation. So in this case, tissue thromboplastin acts as a trigger to activate the extrinsic coagulation pathway. As in for endothelial injury, what happens is platelet aggregation is what that initiates the activation of intrinsic coagulation pathway. So what happens next is all of that we have discussed earlier, which is the consumption of clotting factor and platelets, fibrinolysis, and the presence of fibrin degradation products in the circulation. Now, what happens in specific is that when the consumption of clothing factor and platelets happens, this results in bleeding. And also for fibrinolysis, what happens is there is presence of fibrin degradation products, which inhibits platelet aggregation, thrombin, and fibrin polymerization, which then leads to bleeding as well. And the microvascular occlusion causes ischemic tissue injuries and microangiopathic hemolytic anemia. Now, to conclude or to summarize the diagram, what actually happens is when there is a injury, when there is a cause of intravascular coagulation, there is an activation. Activation happens when the tissue factors are being released. So tissue factors activates the pathway, and then all of the other sequences carries on and takes place. So that's all for my part. Thank you.
Hello, Assalamualaikum. I am Merva Kushera. So, my turn, I'm going to talk about the investigation and the result of the test, plus the treatments. So, basically, we will go to the investigation and the result of the test. Firstly, we can do the blood test. So it may show the number of platelets in the blood sample has dropped. Therefore, the platelets are used up for the blood clotting. And that's the blood is taking for a long time for clot. The diagnosis of DIC is confirmed if test results show abnormally increased quantities of plasma D-dimer. And this is the first investigation that we can do. And the second one was test for clotting factors and clotting time. Basically, it seems like the first treatment that's called as a blood test, but this time it's more focusing towards the blood clotting factors. So we can do the PT and PT test, the test that measure how long it takes time the blood to clot. Also the serum fibrinogen, that we know fibrinogen is a protein that helps the blood clot. And also the fibrin degradation. These are for the investigation and the result of the test. And we will go to the treatments. I've saw a lot of kind of treatments that we can treat for the DIC patient. One of it was blood transfusion. In markedly low levels of platelets and coagulation factors, particularly fibrinogen, may increase the risk of bleeding. And the threshold for transfusing platelets depends on the clinical states of DIC patients. Okay, the response to blood component therapy should be monitored both clinically and with repeated assessment of the platelet count and coagulation parameters following the administration of these components. The efficacy and the safety of the recombinant of B2A in DIC patients with life-threatening bleeding are unknown, and this treatment should be used with caution or as part of a clinical trial. So, basically need consultation from the doctor to see whether the patient needs a lot of platelets or not. So depends on the level of the disease, the DIC level. Second was the heparin. As we know, heparin, the therapeutic doses should be considered in the case of DIC in which thrombosis predominates. A small RTC showed that low molecular weight heparin is superior to unfractionated heparin for treating DIC. As we know, the administration of heparin is not recommended in patients with bleeding or massive bleeding, the type of DIC, due to the increased risk of bleeding, although it is really and very recommended in those who are with non-symptomatic type of DIC in order to prevent the onset of deep vein thrombosis. These are for the heparin. Here I got some of the treatments. Anti-XA agents. Anti-XA agents are just like fondaparinux and danaperide sodium. Okay, it will activate AT specifically to inhibit XA. By the way, anti-XA agents is not recommended in those with a bleeding or massive bleeding type of DIC. And also these drugs are not recommended for the patient with the kidney or renal failure. It's really not recommended. And for the synthetic protease inhibitor, it is inhibitors such as gabazate mesylate and nefamostate will exhibit multiple functions, including the antagonistic effects of the kinin and fibrinolysis. These drugs are often used in the patient with the bleed and massive bleeding and non-symptomatic type of DIC. So it's kind of, there's a huge difference between the anti-X agents and the synthetic protease. And the natural protease inhibitor, use of agent capable of restoring dysfunctional anticoagulant pathway in patients with DIC has been studied extensively. Sorry. And the last one, the anti-fibrinolytic treatments. So it's agents that are effective in treating bleeding, although the use of these drugs in patients with the organ failure or non-symptomatic type of DIC is generally not recommended. And the administration of antifibrinolytic agents treatments in these cases must occur in the early period of the management before the level of the DIC increase. So these are the treatments and the investigations from me. Thank you.